Right, what are we doing tonight? Well, I just thought I'd come on and do a little bit of a Q&A after so many people had said that they had questions regarding low back pain. We've had a couple of questions come through prior to now on DMs, so I'll happily try and answer those. But also, of course, if anyone has any specific questions that they want to ask, then please put it there in the chat. And in fact, I'll use this opportunity to say go. Please do add your questions into the chat as we're going along, and I'll do my best to answer them. So I know that a lot of you are probably familiar with clinical physio. If you're not, welcome. It's lovely to have you on board. Tonight, I think we're going to try and go for around about half an hour, maybe 40 minutes, depending on how much interest there is, depending on what questions are coming through, so that we can try and answer questions on low back pain. And I suppose the idea really is that we're trying to try and answer some of those quite overall rounded questions when it comes to low back pain in particular, that you may not get the chance to answer on placement, or things don't quite make sense, and therefore you've come on tonight to try and answer it. So it's a pleasure to help. Right, first one up is a very simple question. How does the pain gate theory relate to chronic pain? I suppose I'll happily talk about chronic pain in low back pain, as it were, which I suppose is the same for any kind of persistent pain or chronic pain mechanism. A lot of the time when I'm trying to explain to patients about chronic pain, I find it's quite useful to try and use analogies. So a common analogy that I commonly try and use is regarding an orchestra. And this orchestra has got used to playing one particular tune. And that orchestra has become so used to playing this tune time and time again that whenever they're asked to play any song, the first thing that comes to their mind is this particular tune, because they're so good at doing it. And so the way that kind of relates to the pain gate theory and to chronic pain in general is that if the messages get sent up to your brain are the same messages all the time, then the brain will respond in the same way all the time, just in the same way if the message is said to the orchestra, play a song, play a song, play a song, the orchestra will play the same song, and the same message will come down from the brain back towards our low back. So therefore, if sensitivity is raised within our nociceptive system, and when we have increased central sensitization, as it's probably said, then the same message gets sent down in terms of pain levels. The reason behind that, or part of the reason behind it physiologically, we're still trying to learn about this, by the way, it's still something that we don't fully understand, is that we create pathways, or our brain, I suppose, learns pathways, because, it's whenever there's anything neural going on, it's to do with neuroplasticity, it's to do with learning things, just in the same way as playing the piano, we learn how to move our fingers in a certain way. And pain is, sometimes described as a learned response. In what it should be is that it's there to provide a message up to the brain, and then the brain responds with pain, i.e. if you're moving towards that hot flame, then the temperature is picked up by the fingers, sends a message up to the brain saying it's really hot, you need to move your hand, and the brain says, all right, I'll do that, I'll send a message of pain down so that the hand gets moved away, and that's what happens. But the way that becomes challenging in a low back pain patient, for example, is if they do the same movement over and over again, and the message is sent from the lower back, from the muscles up to the brain to say, we don't like this very much, then the message coming back down will be a pain message so that we stop doing it. So it's important to show the orchestra a different song. It's important to allow the orchestra to learn a different song, or at least start learning songs which are easy for them, and then they can gradually build up to the harder songs, i.e. if you can find a way of making it easy to move your lower back in the early stages, then you can gradually build upwards towards more easier exercises and better movements. Long answer, Leah. I hope that helps. Clara, Tiganis, Kalispera, what are your thoughts of using Mackenzie for low back pain? I suppose that I use it infrequently. I think I use it in a very simplistic manner, but again, this is just personal choice. It's not to say that it's right or wrong generally, it's just what I do. How do I use it? Quite simplistically, if I ask someone to lean back and I say, how does that feel? And they say, oh, that feels better, then that tells me that lumbar extension is perhaps a movement that they like. And as a result, if they say, oh yes, actually leaning back feels better, then I might say, okay, well, let me try some movements with you now, and let's see if we can make it easier for you to move. So I might then get them to lie down, might get them to do some extension exercises in prone, and get them to stand up and say, all right, well, having done those exercises, would you mind having a look at your movement now? And if they say, oh, that feels loads better, then I say, oh, great. In that case, I would like to send you home with these exercises. But I certainly don't go into most patients with low back pain saying, I'm going to do Mackenzie today. But if something just, I don't know, ticks a box with me, if they say, oh, it feels so much better when I stand up, it feels so much better when I lean backwards, it feels so much better when I'm lying on my front, then that kind of points me in that direction. There was another couple of questions that I will come on to. Great question from PK Wong. What are some of the public health initiatives for low back pain in MSK outpatients? Great question. I think one of the big ones from the CSP in the last couple of years has been about trying to reduce myths about low back pain. There's a good education leaflet, or I think it's a series of posters out there, which is all about dispelling myths about low back pain, about things like if you have a bad back, then you'll always have a bad back, that it's bad to move and things like that. But otherwise, one of the biggest ones is something that we're constantly battling with: more exercise and better diets, which are, of course, very well, diet indirectly is related to low back pain, but exercise is a huge part of back pain, and the NICE guidelines for the UK demonstrate that aerobic exercise and movement in general is incredibly evidence-based for low back pain. Seen some others. What's your thoughts on putting patient into subgroups management of non-specific chronic low back pain? I do have a triage approach to low back pain patients in general, where, and you may have seen me talking about this if you've been to one of our live courses on making low back pain less scary for physiotherapists, where we can separate patients into simple low back pain, neurological changes, or sinister pathology. So I might put patients into a simple low back pain category, but I wouldn't necessarily then subdivide them in that. If they're in a category of non-specific low back pain, chronic or not chronic, then I will probably use a lot of the same things: education, exercise, advice, discussion on analgesia, diet, etc. So then I suppose the idea being is that I'll use all of those different methodologies no matter what the patient is in terms of non-specific low back pain. Hope that helps. Paracolo. Hello, do you think stress and sleeping problems affect low back pain? Yeah, sure, Ileana. Generally speaking, yes. We know hugely that psychological factors do have an effect on low back pain. It has a big effect on pain in general. If we're coming back to the previous question that was asked a second ago about the pain gate theory, there are different things that influence central sensitization within the body, and certainly being in a situation where you're more stressed is evidence shown to heighten the sensitivity of us generally, and heighten the sympathetic nervous system, I believe it is. And as a result, it makes us, being stressed makes us more on edge. That makes our muscles seize up, or perceivingly seize up. It means that we get more tense, and naturally that has an effect on low back pain. But just being stressed in general has an effect on our mood. And we know that when we have lower mood, it feeds into pain in a negative way. Very much the same with sleeping. We absolutely need sleep. It's a pivotal part of our bodily processes. We absolutely need it for healing, for recovery, for rest, for re-energizing ourselves. And if we don't have that, then it's going to affect any level of pain, but absolutely low back pain as well, because of the psychological impacts of low back pain, especially if it's low back pain which is stopping the patient sleeping, because naturally they'll attribute everything to do with their sleep to the fact that they've got this horrible back pain. And when they have this horrible back pain and it's not letting them sleep, then they get really fixated on the back pain, which, as we know, feeds into that central sensitization picture. Do you feel like putting more information on low back pain out there can help patients understand? Yeah, absolutely, 100%, Thomas Sunshine. We have a YouTube video which is about challenging yellow flags in low back pain. Obviously it's on YouTube, so it's free to watch, but it kind of goes into education regarding psychological factors in diagnosis. So, as you said, talking about slipped discs or crumbling discs or degenerative disc disease, and how those terms are so horrible. So it's absolutely one of the things that physios around the world are really trying to do, to put education out there that's less threatening for low back pain. Papito, what do you define as true radiculopathy, or when is it just radicular pain? Great question. So I'll just throw this out there. We've got an on-demand webinar which is on lumbar spine red flags, which you can find on our website, www.clinicalphysio.com/webinars, and then click on the on-demand section, and it goes into some good detail about radicular pain versus radiculopathy. So for me personally, the key traits of a radiculopathy is when someone has either myotomal changes, dermatomal changes, or a change in their reflexes, because those three symptoms are very common symptoms as a result of nerve root pathology. Now, of course, it could be due to other things. If it's bilateral, it could be a central cord problem, like an upper motor neuron lesion or a spinal cord compression. But generally speaking, those are the three symptoms that I look out for when it comes to radiculopathy. In my book, if someone's got fantastic reflexes and no problems with sensation and no issues with their strength, I don't call it a radiculopathy. It therefore might be that it's then radicular pain if they are just having pain. And we talk about on the webinar that the key word with radicular pain is pain. Pain is their main symptom and nothing else. You can have a radiculopathy that accompanies radicular pain, but when it comes to radicular pain, pain is the main feature, whereas when it comes to radiculopathy, myotomes, dermatomes, and reflex changes are one of the key features. Clara, if your patient comes into clinic with low back pain and wanting a specific diagnosis, you've ruled out your red flags, neuro, but unsure where the pain could origin from. How would you manage to treat this patient? Good question. First of all, one of the best things that you can do is say, I've got some, I'm really pleased to say that I've gone through my whole assessment and I don't see anything serious going on. I've checked your nerves, they all look okay. I haven't seen any sign of anything nasty like a fracture. You don't present today as having anything sinister like cancer. And it's good to say those things, because it ultimately, your patient might have been for months thinking, oh God, there must be something really wrong with my back. It's not getting better. It's only getting worse. That must mean something's terrible going on. And even if it sounds dramatic to say, good news, I don't see any signs of something sinister like cancer, that can be a really important thing to say. So that's definitely number one thing. I could say that, we don't always, I think it's okay to be honest and say, we don't always know if it's specifically a disc problem, if it's specifically a facet joint problem. There are clues that can take us in different directions, but ultimately we treat all of them the same. And I suppose I try and come away from the idea, I try and bring the patient away from a specific diagnosis thought process for them, because it is threatening. Diagnoses within low back pain are threatening. Sciatica is a dreaded term. And patients say, oh, I've got that sciatica thing, and they really worry about it. So I try and take them away from the idea of your diagnosis is bam, And they talk about this with MRI scans and how patients who are told their MRI scan report in detail and results do worse than patients who are not told their MRI scan reports in detail, because of the fact that they hear these scary words like facet joint irritation and discopathy or disc herniation or prolapse disc, and it makes them really worried. So I often try and normalize things and say, lots of the things that you're presenting today are very, very common. We have really good experience in treating low back pain by getting things moving, adjusting pain control if need be, general exercise, relaxation, reducing stress, etc. So I suppose I try and take them away from that diagnosis. And if they're saying, yeah, but what's the diagnosis? Then sure, I might come back to them and try and say, well, you present with symptoms that look like it might be coming from one of the joints, or your symptoms look as if it might have irritated a disc, and I will very specifically use the word irritated rather than compress, impinge, tear, herniate, prolapse. Irritate, I think, is a really nice word, because something can get irritated and then can stop being irritated. So certainly the language that you use is important. Signs that the pain may be better treated or treated in collaboration with a chiropractor, Erica. It's a really good question. I suppose honest answer, I've never really thought about it. I've never really said to a patient, oh, I think based on what you've shown me, you need to see a chiropractor. And I suppose that's probably because physios and chiropractors naturally have different beliefs. Sure, there are things that we agree on, but I think that there are lots of things that we disagree on. I work in the NHS in the UK, the National Health Service in the UK, where a lot of the ideas that we try and hone in on patients is about independency and exercise rather than hands-on, and movement being better than manipulation. So to be honest, I personally stay away from a lot of manual therapy. It's just a personal preference. Doesn't mean there's anything wrong with it. It's just me. And therefore I personally haven't ever said to anyone, you must go to a chiropractor. At the same time, I will never say to anyone, you mustn't go to a chiropractor. If someone says, oh, I'm thinking of going to see a chiropractor, I might say, well, to be honest, it's not really fair of me to give you advice on that either way. If you feel it's something that you want to try, then it's your choice. Lewis. Oh, sorry. Text is going funny. Down. Lewis, are you a fan of the term non-specific low back pain as a working diagnosis? Since qualifying, I'm less keen to use it as patients feel there isn't a driver of their symptoms. Difficult one. It was once explained to me, take from this what you will. It was once explained to me that if you're in a court of law and the judge says you've written there that it was a disc herniation, how do you know that it was a disc herniation? If you don't know, then you perhaps shouldn't be writing it. That was once said to me. I have no problem with the term non-specific low back pain. As I potentially said to Clara in the last question, I try and stay away from diagnoses with patients, because evidence has demonstrated that it's threatening, as I said with the MRI scan thing. Instead, I try much more to talk about, rather than what it is, I try and talk about how I can get it better. Sure, you can use colloquial words like, looks like your muscles are quite stiff, or it looks like your muscles are a little bit weak, we could get them stronger, or looks like you don't really like moving in front of you, sometimes that can be part of a disc problem, or yeah, it looks like you've got pins and needles in your legs, sometimes that indicates to us that nerves are irritated. But I suppose the idea there is that, and again, this is just personal choice, it's just what I do, I try and do things like that than be very specific with patients saying, yeah, looks like you've got a disc herniation at L5S1. And that makes them go, huh? What on earth is he saying? Or, yes, it looks like you've prolapsed a disc. That's very threatening, as opposed to, I think it looks like your disc is a bit irritated. Both might be true, but one is a lot easier to hear than the other. And so I suppose I commonly try and use terms that are easier for patients to hear, because hopefully it means that they feel more comfortable in how to manage it. Hope that helps. Imran, how important to you is core strengthening a low back pain rehab program? A lot of the time, strengthening is very important. Generally, as a physiotherapy world, I think we are gradually moving away from this idea of core strengthening. The idea being is that sometimes patients think that they need to have this rock solid tree trunk in the middle of their bodies, and if they don't have that rock solid tree trunk, then does that mean their spine's unstable? Does it mean that they are going to break because they don't have this shield around them? And so, again, one of the biggest things I think I've learned about low back pain is try and be, as I've said a second ago, I suppose, less threatening. Try and be less forceful. Try and be less direct. There's nothing wrong with being indirect if it's going to help your patient. And so it might well be that I say, I think we could do with getting some of those muscles stronger. I'm sure if we did, it would make it feel like your back's more supported, rather than, yeah, you look like you're really weak. It looks like things are a bit, because sometimes to patient, weak means unstable. And hearing that you've got this unstable spine makes you think like, as I said, you've got this tree that's going to fall over. But generally, yeah, strengthening is certainly things I use a lot, particularly strengthening around the gluteal muscles is something that I do a lot of. Sam, good evening to you, my friend. What's your thoughts on massage therapy and other manual therapy techniques? You may have heard me say earlier, I personally don't do a lot of it. Is it the way that I've been brought up in the NHS? Maybe. Is it because that's the evidence is moving away from those things these days? Maybe. I suppose the idea is that I think I've learned over a long period of time that low back pain is it's a physical thing. Of course it is. It's a physical symptom, but a lot of the thought processes that go on with low back pain can be just as challenging for patients to get over as the physical symptom itself. It's a very mental symptom, low back pain, because of the mass hysteria about it in the media. If you have a bad back, you're always going to have a bad back. Oh, this dreaded sciatica and all that kind of stuff. So I suppose that manual therapy and massage therapy might promote dependence rather than independence. And so it's personally something that I don't do a lot of these days. As a physio, how effective do you think cognitive behavioral therapy components are in treating chronic low back pain? Absolutely. Physio motion, absolutely. More and more. Ileana, good question about how do you manage the fear of movement. Hopefully I can come on to that in a second and perhaps link the two. We've done an online webinar on yellow flags, which I hope could help you. In regards to the yellow flags talk, we discuss a lot about trying to break down barriers and trying to challenge behaviors. So, fear of movement. What's your fear, I might say to the patient? They might say, oh, I can't bend over and reach the floor because if I do, my back's going to break in half. Okay, so we need to first of all get bending more comfortable for you. Now, when patients have a fear, it is difficult to challenge the behavior because if it goes well, great. It might help the patient get over their fear. If it goes badly, it just reaffirms their belief and it reaffirms the behavior that they're involved in. So, for example, let's say patients finds that when they reach forward and touch their toes, it causes this terrible shooting pain in their leg. And there I am saying, I'm going to try and challenge this by trying to demonstrate to you that bending over isn't as bad as you think. Bend over and touch the floor. If they bend over and this shooting pain comes in their leg, ow, see, I told you that's exactly what happens. I can't bend over because when I do this, shooting pain goes in my leg. So you really have to choose your moment. And I suppose the idea being is that challenging that behavior might start with, okay, well, could I just maybe trying to not make it so dramatic? May I just look at how it is for you to reach forward in sitting? Could I just have a look at that with you? And I just have a look at it with them and they say, they might say, oh, that's really sore. And in which case, okay, we might need to take it a step back. But if it's easier, I might say, oh, good. Okay, well, maybe this is a way that we can start to get into bending that might be a bit easier for you. Oh, okay, maybe bending might not be so bad after all. So start with the easier method of getting into bending. So, for example, doing it when you're sitting, or instead of trying to reach for the floor, can you reach for the edge of the bed? Or can you reach for a chair? Or can you reach for a stool or a step? And then eventually, over a longer period of time, how long? depends how long the patient feels irritated for. If it takes them 6 weeks just to reach a chair, it might take them another 6 weeks to reach the stool or to reach the step. Conversely, it could be that today they reach the chair and they go away and they say, do you know what, after you tried that thing with reaching with me, I just got better and better at it and I got more confident with it. So in answer to your question, how do you manage the fear of movement when the time is right? I might try and start challenging it by looking at that particular movement and trying to demonstrate to the patient that it's not so bad after all. It's a bit like the orchestra. If you can show them that there is a different tune, then they might try and play that different tune. Easier said than done. It certainly will go wrong at times where you say, go on, try and reach the floor. And they go, ow, that's my pain. I told you. Now you've just reaffirmed to me that I can't reach the floor. So you've got to pick your moment. You've got to pick your patients and make sure that they are confident ones. Start off with easy things and gradually increase it. Okay. What other treatment options would you consider for patients who are unwilling to comply with an exercise program? Great question. I'm going to give you a not very nice answer, which is I would ask why they're unwilling to comply with it. Rather than saying, oh, well, if you're not doing exercises, then we'll just do this. Because I think that exercise is a huge part of low back pain. So I would try and get into why is this not possible for you? Is it because you're afraid of it? Is it because you can't be bothered? Is it because you don't have time for it? Because I think those things are going to be more important than just pushing them aside to, right, exercise hasn't worked for you, let's go on to manual therapy. Because by doing that, you're demonstrating to the patient that exercise isn't worth it, or it's not worth their time bothering to do it, etc., etc. I know that's a not so happy answer, but I hope it makes sense as to why, because I think that exercise is hugely important. Great, you're very welcome, Erica. Let me just see if we've got any other questions. We haven't got any other questions at the moment. Oh, no, we do. Sorry. What are your thoughts on lumbar first aid exercises? Lizzie, when you say lumbar first aid exercises, hello, by the way, Lizzie, it's lovely to hear from you. What are your thoughts on lumbar first aid exercises? I'm guessing there, correct me if I'm wrong, write down below in the chat and I'll come down to you. I'm wondering if you're asking about, for example, if someone has sharp spasms of low back pain and they're suddenly in trouble, in which case, which is something that I did with a patient only in the last few days, is I will very much have a look at what's comfortable for you. Rather than saying, oh, you need to do this, this, this. If they find all those three things really uncomfortable, then it doesn't get them anywhere. Whereas if I say, let's try a range of different things and you can tell me what's comfortable for you, then hopefully it reaffirms to them that there are things that they can do. And again, it's giving them the independence, because I'm saying, which exercises out of the ones that I've chosen do you like? And automatically that's less threatening to the patient because they're choosing, which ones out of these do you like? I like that one and that one and that one. They're much more likely to do those than if I said, I like this one, this one, this one. I hope that answers your question, but if that's not what you're asking, then please put it down below and I'll try and come to you. Oops. Diagnosis of a slap lesion is difficult to confirm. Thank you very much for the question, my friend. We're doing low back pain tonight. I appreciate your questions about a slap lesion for the shoulder. We are planning to do a shoulder one next week, though, of an Instagram live. Diagnosis of slap lesion, thrower's test, subjective history of trauma. I will go through that in much more detail in the future. Confirmed diagnosis without MRI. Lots of the time we find that MRI isn't needed to diagnose that effectively. Could some cases of low back pain be referred pain from an issue in the other part of the body? Sure, Erica, absolutely. I think in particular, if I come to mind about, let's say, a gluteal tendinopathy, where someone might have a tendon issue, whereby it might be that they have weaker glute muscles, for example, then that can certainly have an effect on low back pain, because our back and our pelvis relies on that gluteal strength in order for it to function well. Otherwise, I've certainly seen patients who might have had, I remember a specific patient who had a foot drop, and they were, because they had a foot drop, they were walking differently, and as a result, they developed some low back pain. So that's another example. Is yoga Pilates encouraged for self-management? Sure, if it's comfortable for the patient, then certainly. I think especially if the patient, again, it comes back, we were saying a second ago about exercises that the patients like. If you have a patient who says, I've always done yoga and I've always loved Pilates, shall I go back to it? If I can find a way that's comfortable for them and encourages them to do it, then it, again, promotes independence for the patient because they now have more tools to help themselves with their own back problem, as opposed to saying, no, you mustn't do that. You must do my exercises. And they say, I need to see this physio all the time. I'd much prefer that they were happy with what they needed to do than I was happy. So I hope that answers your question. I'm trying to go down. I've had patients turn up in my clinic having told they have sciatica and not to move your back. Do you think more should be done to increase GP awareness, Luke? 100%. One thing I will say, especially as we have a specialist GP in Jack on the team, is that not all GPs are wrong, but you are absolutely right. It might not come from a GP. It might come from it could come from another physio. Let's be bluntly honest. It could come from another physio that's told them that they shouldn't move their back. So it's not necessarily just a GP problem. I think it's a whole profession problem around every discipline, whereby the fact that this is still happening demonstrates that as a world we still don't agree on the same principles. So I think it's about education of everything, of everyone, my friend, and that's why I suppose teams like the CSP have come out with things like that, to come out with things like the myths about low back pain in order to try and dispel some of these myths. And of course, then it's if that patient turns up at our door saying, I've been told not to move, don't be afraid to challenge it. Sure, don't do it the second they walk in the door. Something that we talk about on the Yellow Flags on Demand webinar is that, if your patient walks in, sits down and says, I'm not going to move very much because I've been told not to move my back. If you challenge them and threaten them in the first 5-10 minutes when they haven't even got a chance to get comfortable with you yet, their first thought of you is that you are a potentially threatening individual. Whereas if you give it time for them to trust you and build a rapport and for them to get comfortable with you, then they are much more likely to be able to interact with you and trust you. So I hope that helps. Scroll down. How to differentiate low back pain from hip pain or other referred pain? Good question. I suppose that it comes down to your objective testing. Does reproduction of symptoms is really important. So, for example, if you're going through active range of movement of the lumbar spine. Let's start again. So patient says, yes, my low back pain is here on the right side of my low back. Okay, let's have a look at different tests like lumbar spine tests. And if you are able to specifically reproduce their right-sided low back pain with those lumbar spine tests, then yeah, it might indicate that it's more likely to be involved with that. I think one of the things that you find definitely with testing the hip is that look out for, when you're testing the hip, is their low back pain reproduced or is hip pain reproduced? I suppose the premise being is that it's apart. We said about the gluteal tendinopathy earlier, which I suppose is that low back pain is a secondary effect of the gluteal tendinopathy. And I suppose in this instant, we're using the word referred pain. I suppose I would probably term it slightly differently. I might call it a secondary effect pain, i.e. they have a weak gluteal tendon, they have a weak glutes, and therefore a secondary effect of that is low back pain, rather than their hip is causing directly that low back pain. Hip tests will probably, if they're irritable around the hip, then it's a hip problem. But if those hip tests create some low back pain, then I suppose it might indicate to you that a secondary effect of the hip is that they've developed low back pain, i.e. because they have tight hip muscles, does that mean that they've generated their low back pain? Sally, do you ever talk to people about the habitual nature being a cause of pain? Yeah, sure. There is a huge movement at the moment. You might have seen it. I know Anamikins is a big advocate of this, that posture, it's not, we're going away from this idea that this posture causes this pain. However, what I do believe is that certain habits and certain postures will certainly have an effect on low back pain. For example, let's say your patient is saying, when I sit on the sofa, it's more painful. When I sit on a dining chair, it's less painful. That's a relatively clear indication to me that when they sit on a softer surface, it might make it more painful. The difference in terms of what I was saying a second ago with anamikins is the suggestion that everyone in this world who sits on a sofa will get back pain. That's incorrect. But if you can demonstrate that there's a clear relationship with your patient and the habit, i.e., if I sit on the sofa, I definitely get back pain. When I sit on a more hard chair, it's less painful. That's clearly a difference. Okay, how do you diagnose buttock pain, piriformis, low back pain, ischiofemoral impingement, etc.? Good question. I think that one thing to say is that I might treat a lot of those similarly. Piriformis syndrome, I say that with quotation marks because, again, it's one of those things that we're moving away from, is commonly discussed in the past, where it presses against the sciatic nerve and causes sciatic pain down the leg. Ischiofemoral impingement, again, the area of the ischiofemoral region is much more distal in the distal buttock, as opposed to low back pain, which tends to be more upper buttock. So sometimes just the area of pain is a factor in that. For us, Leah, for us students who aren't too confident dealing with patient anxiety surrounding low back pain, do you have any top tips? Certainly. The first tip I'm going to give you is don't worry. It's certainly not the case that as a student you are expected to be an expert in talking to patients about low back pain. There are band 5s, band 6s, band 7s even who still have trouble with it. So please don't put yourself in a category of I'm a student, therefore I'm not good enough or whatever. Listen to advice. Look, if you can, supervise seniors actually having a chat with patients about these things. Tips that I do, which actually I've just seen a question below about how to set goals with patients with dementia. Dementia. That's a slightly different topic. I'm going to one day bring in my colleague Beth about that. Dementia is naturally difficult. If I could take your question into low back pain and how do you set goals for patients with low back pain, in the same way of dealing with patients' anxieties, I think making it personal to the patient is really important, i.e. listen to them, try not to dictate the conversation, try and listen more, which will fuel the conversation more. Set goals which are personal to them, i.e. what are you struggling with at the moment? What do you want to try and improve on? It's much more important that I address what they say than what I say. So coming back earlier, what exercises do you like is much more important than these are the exercises that I like. What do you think is going on when you bend forward is much more important than I'm going to tell you what's going on when you bend forward. Sorry, I was saying a second ago, listen to your educators, having those conversations with patients. It's a really different situation to actually watch it in action than just hearing it. I think I would also suggest potentially having a look at Peter O'Sullivan stuff. If my brain serves me right, I think that Peter O'Sullivan might have some stuff on YouTube where he's actually gone through patient interviews in the past. So I hope that helps. And of course, if I can, maybe I'll do another, as I said, we've done a Yellow Flags on Demand webinar, but maybe I need to do something on specifically patient conversations, which might be good. Oops. Sorry, things are jumping all over the place. What's your opinion on SIJ dysfunction, Dan? So, we are, as a physio world, moving away from SIJ tests in isolation. Sometimes we use them in conjunction, and certainly in our YouTube videos that we've done, which you can check out, YouTube Clinical Physio, we talk about using the tests together as a cluster. Honestly, I think of it more in terms of treatment. I might very well treat low back pain and SIJ dysfunction in very similar ways. I have quite a hands-off approach. I do a lot of exercise stuff. I do a lot of gluteal strengthening for both. I do a lot of education and advice for both. It's quite similar, personally. So I suppose the answer is no. I do them in similar ways. Lizzie, I'm so sorry. They are lumbar rolls, rolling side to side, glute bridges, rocks. Yeah, absolutely. A pivotal point is that I might well try, rather than saying, Mr. Patient, you must do lumbar rolls, bridges, and rocks. I will try all of those with the patient and say, which one of those did you like? And if they said, I like that rocking one, I like that bridging one, but I didn't really like that roll one, I'll say, fine, take the roll one out, carry on with the other two. I've been trying a lot recently to try and work on what my patient likes, because that's much more important than what I like. Ileana, how do you manage flare-ups? Lots of advice, lots of reassurance, lots of don't panic. This happens to everyone. And it's very much the case that in the same way that it took a couple of days for it to get worse, it could take a couple of days for it to get better. Keep moving. Painkillers, painkillers, painkillers. Don't be threatened by talking about the patient using painkillers. Yes, you might, as a physiotherapist in the UK, we're not allowed to prescribe. We're not allowed to tell the patient you can take this medication. We must say, speak to your pharmacist or your GP. But it is certainly okay to say you should have a chat with someone about your painkillers, because we need to get your pain under more control. Thank you, Lizzie. How do you know if it's facet pain or muscular? Good question. Facet joint pain tends to not like extension and side flexion towards, i.e. if you are with your patient and they say, where's your pain? And they say, on the left side. And I say, okay, bend forward. Oh, that feels loads better. Go down to the right. Oh, that feels loads better. Extend. Oh, that feels a lot worse. And down to the left. Oh, that feels a lot worse. Extension and side flexion towards is generally the textbook indications for facet joint irritations. However, I suppose one thing I've learned from practice is that it's not always in reality, it's not always as they say in the textbook. Sometimes it might be, yes, flexion's great and extension's terrible, but at the same time, sometimes it can be that they don't like extension and they also don't like a little bit of flexion as well. Not always clear cut. But yeah, certainly lots of glute strengthening with that. Can a physiotherapist make a diagnosis? What about that debate? It's no debate for me. Physiotherapists can definitely make diagnoses. I think we're probably one of the best placed people to make musculoskeletal diagnoses compared to lots of other healthcare professionals. I don't mind saying this, that I think a lot of physiotherapists will be the best diagnosers out there. Yeah, that's my answer. Leah, that's very kind of you. I'm glad to hear it. I think we're kind of, we've been going for 45 minutes. That has absolutely flown by. Yeah, Reese, what are your thoughts on Adam Meakin's opinions on manual therapy? I can't deny it. I'm of a similar opinion. I focus a lot on exercises rather than manual therapy. Again, it's an opinion. It doesn't mean that I'm definitely right. I will never ever say that I'm definitely right, but I'll always tell you my opinion and give you justification behind it. I focus a lot on exercises. I focus a lot on movement. I focus a lot on patient education, patient advice, making sure that they know the answer. It's much more important that they know the answer than I know the answer. It's much more important that they feel independent, and I don't like to make them feel like they should be more dependent on me because they only get better with my manual therapy through my hands. That's me. How do you have a conversation with overweight patients that their weight could be the cause of low back pain? Analogies, I suppose, is a good way, Island Dreamer. For example, if I gave you a sack of potatoes that weighs 20 kilos and asked you to walk around with that sack of 20 kilos all day long, how do you think your back would feel afterwards? Probably quite sore. There you go. Yes, of course, you may not always be so direct like that. But I suppose you can make it still indirect in that manner by saying, your back has to carry the load that's given to it. if it has less load to carry, it can feel easier. Or take it away from that particular patient and say, I've had lots of patients in the past where they have found that losing weight has been helpful for them. You're not saying that your patient's overweight, you're saying that patients in the past that you've dealt with have found that losing weight has been beneficial. And then, of course, you can give them the sack of potatoes idea as well. Yes, motivational interviewing, Ashley, absolutely. Thanks, Erica. Thank you, everyone. How do you manage a chronic low back pain patient? Hopefully a lot of the conversations I've had. Loads of education, loads of reassurance. Explain to them about the orchestra idea. Explain that it's normal that these things happen. And a huge amount of weighting goes on to what do they want and what do they like, i.e. which of these exercises suit you? Not you must do this, this, this. Which of these exercises suit you? They're going to feel a lot. Imagine you said you need to do this, this, and this. And in their mind, they're going, how the hell am I going to do those exercises? That's incredibly threatening. Whereas if I say, which of these do you feel are best equipped for you? I think I could probably do that one and that one. Great. How many repetitions would you like to do of those? Maybe 8 and 6. Imagine if I had said you need to do 15 of both of them. So I don't think there's a problem with, guiding the patient, but allowing them to make decisions. Because again, if I said, no, you have to do that 15 times, they're going to feel a lot more threatened than if they said, I think I could do 8. And I say, great answer. Go for that and see how it goes. Cool. I think we're winding down. Jill, one of our biggest supporters. That's very kind of you. I don't even know what I know and what to ask. So thank you for doing this. It's a pleasure. That's what we're here for. Always remember that whether you're a student, whether you're a junior, whether you're a band 6, every physio has gone through exactly the same steps as you beforehand. I can promise you that there was never, ever, ever a student who woke up on their first day of physiotherapy learning and they were as good as a band 6. I can promise you that. And therefore, it's normal that there is a journey in front of you, and all you need to do is walk the steps of the journey, and just like everyone else. Cool. I think, how to address low back pain in pregnancy. Good question, Ema. It was once explained to me that pain in pregnancy can be due to tightness or lack of strength. If it's tightness, give them stretches. If it's lack of strength, give them strengthening. That was what was once said to me. But I think that a lot of the time strengthening is a way that I look at things now, especially as we're commonly talking about this debate that actually is tightness just an indication that something's weak. Anyway, that's another debate for a different day. You're very welcome, everyone. I think we're pretty much coming to the end of it. We've been going for 50 minutes, which I cannot believe because it only seems like a minute ago that it was 7:30. Thank you all so much for joining us. I really hope that you've enjoyed this. I love doing things like this, and I'm sure there'll be more. If you have been interested in some of the stuff that we've discussed tonight that's been on our on-demand webinars, such as the Yellow Flag on-demand webinar and the Lumbar Spine Red Flags on-demand webinar, then you can head over to our website, www.clinicalphysio.com/webinars, click on demand, and you can catch those there. Otherwise, thank you so much, everyone, for your time. It's always a pleasure to see you. Thank you so much for joining us. Thank you very much for supporting us on Clinical Physio, and we look forward to seeing you very soon.